Hello, I'm so sorry that last video got cut off. So let us just head back to the collecting duct and antidiuretic hormone and kind of look at what's going on here. So again, antidiuretic hormone, this is going to be a sometimes hormone that is released in the event that we need to conserve water. Perhaps we are dehydrated. So let's just take, oops, where's my pens? Let's just take this for example. So if we are looking at a situation where maybe we're really hydrated, so this would be a no ADH situation. So maybe we are drinking lots of water and we are very hydrated and we're taking really good care of ourselves. So that is going to reduce the osmolality of extracellular fluids because we have plenty of water and not a lot of solutes. So that will result in a reduction in ADH release from the posterior pituitary. Again, remember, it's one of those neurohormones manufactured in the hypothalamus, and then that neuron stretches all the way down to posterior pituitary, where it will be then released and function like a stereotypical hormone. So the target for this hormone is going to be the distal convoluted tubule and the collecting duct of the nephron. So that will reduce the number of aquaporin or water channels in the collecting duct. That's going to decrease water reabsorption. So then we end up with a large volume of dilute urine. So again, fluids that are in the distal convoluted tubule are going to be about 100, 150 milliosmoles. And then as we head through the collecting duct, okay, again, watch these gradients. So if our osmotic concentration in here is only 100, and then outside in the renal medulla, it's about 300 milliosmoles, and then again getting saltier and saltier as we head down. That does create a gradient for water to move out, but water can't move out if it doesn't have the aquaporin to travel through. So we will simply ignore that gradient if we are contained within the tubule, and there is no aquaporins to facilitate release. So then we end up with a large volume of very dilute urine. Any of you that are on kind of that pee clear by noon campaign, maybe you're drinking a large bottle of water or trying to get a gallon of water down in a day, you probably are one of those people that is peeing out a large volume of dilute urine. Usually the urine color will tell you that if you're not able to quantify and figure out what the urine volume is there. And what do we mean by large volume? Again, 1 to 2 liters is a normal urine loss per day. If you're someone that's peeing 4 liters, you're probably really hydrated. Again, always good to be hydrated. You don't want to be overhydrated though, because you will start to wash out these gradients that the nephron loop and the collecting duct depend on. So if you are someone that's like a super hydrator and then one day you don't have your water, you're going to feel the effects of dehydration much worse than someone else because you're not going to be able to preserve. And again, let's just think of the camel. Oh, they must have great renal medullas and great collecting ducts. Okay, so let's take the other example here. So let's say we are dehydrated. Okay. Let's get rid of this. Go away. Okay, so here's our woman running in the desert. Bad choice. Okay, so if we are very dehydrated, we're running through the desert, maybe there's not enough water checkpoints on our marathon run here. This is going to increase the osmolality of extracellular fluids. Again, 300s are normal, so maybe we're just a little bit above that. That will stimulate ADH release from the posterior pituitary. That will increase the number of aquaporins in the collecting duct, and that will increase water reabsorption. So here we go. The big difference in this figure is now we can see water reabsorption. And again, as long as there's a difference of about 200 milliosmoles between the inside of the renal tubule or the collecting duct and the extracellular fluid, which is going to be that gradient across the renal medulla, then we will get more water reabsorption. So we're going to reabsorb, reabsorb, reabsorb. And that will help conserve water, and that will help us keep us at a normal blood pressure and prevent us from getting any of those dehydration symptoms, thirst, dizziness, right, fatigue, things like that. So then we will produce a small volume of concentrated urine. So if you are someone that pees like bright yellow and doesn't drink a lot of water, you probably have maximum ADH activity in your body, and you should probably go drink some water. Or maybe just not run a marathon through the desert. Okay. Things that inhibit your ADH, just anecdotally, you know, this is always a kind of a fun thing that I like to describe. I used to live in State College near Penn State's campus. I used to work there and go to school there. And tailgating is no joke there. And what's really funny is people would go out and they would tailgate. And if you tailgated in the morning, you usually wanted a caffeinated beverage to keep you up. And then people like to drink alcohol when they tailgate. So sometimes they drink an alcoholic beverage. Or if you're really wild, you will do both and have yourself a Four Loko. I don't recommend it. It's going to do horrible, horrible things to your kidney and to your ADH. And then it's typically cold in tailgate season. So 3 things that inhibit your antidiuretic hormone are cold, caffeine, and alcohol. So even though you are dehydrating yourself, drinking that alcohol, and then just going about your normal day, people that consume a lot of caffeine and alcohol end up inhibiting their antidiuretic hormone. So then what goes on here is that even though they're dehydrated, what's going on in their body looks a lot more like this picture. So you will produce a large volume of dilute urine if you do inhibit your antidiuretic hormone via drinking lots of alcohol, caffeine, or being out in the cold. Some people anecdotally report that you step out into the cold and you're like, oh my gosh, I have to pee. Not quite, but you know, again, it's kind of an evolutionary mechanism. We won't get into the nitty gritty of it, but there are things that work here, and this is a very important hormone for water conservation. Okay, let's clear this. Sorry, my slides are not advancing. Okay. There we go. All right. Oh, this is just a lovely little feedback loop here that is showing us what's going on with antidiuretic hormone. So again, if you needed the feedback loop, we can go ahead and just walk ourselves through that. Again, the osmolality is going up, sodium concentration is going up. So we either need to get rid of the sodium or conserve the water. So we definitely want to do that. Again, we have osmoreceptors that are in our hypothalamus that are going to facilitate producing antidiuretic hormones, sending it to the posterior pituitary. So we will get that posterior pituitary release of ADH, right? The target is going to be the collecting duct of the kidney, and we're going to promote water reabsorption, and that is going to decrease and give us that small concentrated volume of urine, and that is going to help, again, reduce the plasma osmolality, so bringing more water in and conserving that. Okay, so if you just needed to see that mechanism drawn out, we have that there. Okay, so now we ask the question, what's left in the urine? Okay, so what do we actually excrete? When we say excretion, once we've headed through the collecting duct and we're into the minor calyces, right? We're into the major calyces, we're into the renal pelvis, we're into the ureter. It's urine now, okay? So that's going to be what we describe as what's being excreted. So you excrete urine. So once we're through the collecting duct, that's it. I think it's funny when people say like, oh, I have to pee really bad, maybe I'll just reabsorb it. No, that ship has sailed. Okay, you do all of your reabsorption right in the nephron. So once you've hit the collecting duct, once you have that full bladder feeling, that 500 mils of urine in your bladder, you have to get rid of it. There's no reabsorption mechanism. There's nothing that's going to happen once it's in your bladder. So if you feel like you have to pee, you have to pee. There's no way to get that back in your body. The ship has sailed for those mechanisms. Okay, so the excreted is what is coming out as urine. So if you wanted to do a quick little equation for that, so that's basically what is, oops, this thing is killing me today. Okay, so what is filtered out at the filtration membrane minus what is reabsorbed, and then we have to add in what's secreted, and that is going to give us our equation for what is excreted. So we say this is the 1% because this is about the amount of your fluid volume that you're going to lose per day, right? So again, you know, we're talking about our filtrate volume. If we consider our GFR, 25% of the cardiac output, that's 125 milliliters per minute. That's crazy. 180 liters per day. We'd be in the bathroom all day if we were peeing 180 milliliters. So 1% of that is, you know, about 1.8 or 1 to 2 liters of urine. That's normal. If you're more hydrated, right, you can certainly produce a 3rd or 4th liter, but any more than that, you're going to want to call a doctor because you're probably having some kind of osmotic diuresis, or you have diabetes, some sort of concern there. So really that should be where your max is. So what is in that 1%? So again, there's got to be some obligatory water loss. We have to lose a little bit of water, but that's really aimed mostly at getting rid of the nitrogen waste. So urea is your most abundant waste product. We've got ammonium ions, amino acid waste. So really anything with nitrogen in it, that's what's going to be what we're trying to get rid of now. There will also be some acids. Okay, so uric acid, again, that's the thing that has nitrogen in it, and hydrogen ion, we already talked about how we can compensate at the level of the kidney to get rid of hydrogen ion if we're not doing a good enough job getting rid of CO2 and driving that carbonic acid equation in the opposite direction. Okay, so again, we have some obligatory water loss. We don't want to lose too much because obviously our blood pressure will start to drop as we lose fluid volume. So again, there are multiple mechanisms monitoring that. We will lose some ions and nutrients, so some sodium will slip away. We're purposefully getting rid of some potassium so we don't become hyperkalemic. We might lose a little bit of amino acids. We might lose a little bit of glucose. That's okay. If we're losing a lot of amino acids, we might have essentially CrossFit disease, rhabdomyolysis, where we're breaking down so much protein, we're losing it that way. Or we might have diabetes if there's lots of glucose in our urine. So it just depends. Okay, one of the things that you're going to do in laboratory is you're going to assess urine compositions, or at the very least compare somebody's urine panel and take a look at that. That would be very useful to those of you that are working clinically. You learn a lot from blood, but you still got to stick a needle in someone to collect blood. So urinalysis is even less invasive than a blood draw because you just need someone to pee in a cup and you can do a lot of tests. So urinalysis is a very powerful diagnostic tool and one that you will likely be using if you practice clinically. So things to look for, or things that clinicians might be looking for in urine, are laid out here. So glycosuria, having glucose in the urine, should have reabsorbed 99% of the glucose in the proximal convoluted tubule. If not, you probably have diabetes. Proteins. So again, if you're really stressing your body, maybe you're exercising too much, or maybe you have some horrible renal failure, you might end up with proteins in your urine. Ketone bodies, this is a product of metabolism via, an alternate pathway that diabetics utilize because they're starving for glucose, basically. So, that would be a problem, and that would definitely result in ketoacidosis and cause problems with acid-base balance. Hemoglobin, that's going to be blood in the urine. So if you ever pee red or brown and you've got blood in your urine, that's problematic as well, because that means red blood cells are fitting through the filtration membrane, and they shouldn't be doing that. So we might have some kind of nephropathy, a problem with the nephrons. Okay, other things that are in there as well, bile, this could indicate liver failure. If you have too much bile, you should be reabsorbing a lot of your bile in your ileum and recycling that. And then red or white blood cells, that's definitely a problem at the filtration membrane or an infection. So other things that you might calculate during a urinalysis, you might just find the GFR. So in order to calculate someone's GFR, you would have to pee in not a cup, but a very large jug and collect a 24-hour urine. So if you're peeing in a jug, that's the way to find out if you are really making that 1 to 2 liters of urine per day. So to figure out what someone pees in a day and to back calculate their GFR, that will give you powerful information there. If they're underproducing urine and having a renal failure, or maybe they're producing too much urine, that might go hand in hand with diabetes. So the hallmarks of diabetes are polyuria, so many urines, more urine than neural. Glycosuria, right, so having glucose in the urine. And then polydipsia. Dipsia refers to thirst. So you have many thirsts because you're peeing out all your water and your glucose, so it makes sense that you're thirsty. So that would be something that you'd want to look. Glycosuria, believe it or not, now you would use a dipstick in the lab, so don't freak out, those of you that are going into nursing. But what older physicians used to do before we had those types of tests, they would smell and even taste the urine. And if the urine tasted sweet, then we knew that there was glucose in it, and that was a quick way to say, hey, you have diabetes. Thankfully, we don't have to drink urine anymore. Let's hope our hospitals don't run out of those tests, because no one wants to go back to that. And that has to do with the transport maximum. So go back and look at that concept about transport maximum if you're unclear on how glucose winds up in the urine. Okay, they're always going to assess ion concentrations. So again, sodium, potassium, obviously tightly regulated, calcium important. We didn't really talk about magnesium all that much, but it is an important ion. And chloride ions. So just making sure that those are in the normal ranges. We want to make sure that people aren't hypokalemic or hyponatremic, having those imbalances there, because that's going to affect our ability to fire action potentials, our ability to manage fluid volumes and blood pressure and things like that. So hematuria, so that's essentially, again, blood cells in there. So you really shouldn't have red and white blood cells in your urine. So if your urine is red or brown, you're peeing blood, you should get help. If your urine is cloudy, you're probably peeing out white blood cells, and that tells me you have a urinary tract infection. Peeing blood is pretty scary because that's probably your filtration membrane breaking down, so you should get to the doctor quickly. White blood cells, you're going to want an antibiotic to treat that, but it is less alarming and a lot more treatable than a kidney infection or urinary tract infection versus having that blood in your urine. Okay, I pulled this figure from a different textbook, but I think it has a really nice summary of basically everything that's going on physiologically across the nephron. So I'm going to leave you with this. The way to interpret is really just to read the panels, 1, 2, 3, 4, 5, 6, 7, and it's kind of showing you, it's got really everything on it. This is why it's a great summary figure, right? We have the vessels bringing blood to the nephron, our afferent and efferent arterial, right? We can see we've also got the osmotic concentration here, 300 milliosmoles. We've got our PCT. We've got big blue arrows showing water reabsorption here. We've got the vasa recta and the renal medulla picking up that excess water that we're reabsorbing. We've got sodium chloride reabsorption in the ascending thick segment of the nephron loop. And then we've got these dotted lines here showing water reabsorption, because remember, it depends when we get to the DCT and the collecting duct, whether or not we're going to reabsorb water or not. Just depends on how hydrated you are and what your body needs. So this is showing that information as well. So just another figure. There's a key here in the corner if you need to interpret as well. I'm not going to walk through the whole entire thing because we've kind of been there and done that. So this will conclude the renal lecture. I'm sorry for the interruption in the middle. I was trying to do too many things at once, so my recording shut down. So please make sure that you review everything, spend some time. Really critical to know kind of where substances are being reabsorbed, how they're being reabsorbed, and then you know, really how are they getting back into the body. So focus on those blood vessels that are taking things back away. And if you have any questions at all, like absolutely make sure you, you know, submit those to myself or your instructor, and we can certainly have a Zoom meeting and talk about it. So that's it for renal physiology.